Good morning. It's a pleasure to be here, and I would like to thank the organizers for inviting me to present new treatment approaches in ovarian cancer. So we'll start with PARP inhibitors. So DNA damage is actually a common event during the cell cycle, and the PARP enzymes are important in repairing single-strand DNA damage, while the BRCA genes encode for proteins that are important in repairing double-strand DNA damage. So PARP inhibitors prevent the repair of single-strand damage, and this leads to double-strand damage during the cell cycle. And this DNA damage cannot be repaired in BRCA-deficient cells through the process of homologous recombination. So this is the reason that the final result is apoptosis in the BRCA-deficient cells. There are two mechanisms through which the PARP inhibitors can cause apoptosis. One is catalytic inhibition, and Niraparib is a good example of that. Through this process, the PARP inhibitors compete with the catalytic side of the PARP enzymes. So they really inhibit the enzyme, and this causes unrepaired DNA break, as we discussed. But there is a second mechanism, and this is the PARP trapping, meaning that the molecule of PARP is trapped in the DNA, and that alone causes additional damage beyond the catalytic inhibition. And we see that the new agents have worked through both mechanisms and with just various ratios. The first PARP inhibitor, Olaparib, was approved in 2014 in patients with a BRCA-mutated ovarian cancer who have failed 3 prior lines of therapy. This approval was based on the response rate, which is about 35%, and based on the duration of the response, which is in the range of 8 months. The approved dose is 400 milligrams twice a day, and for those of us using the dose, we know that it is not uncommon to dose reduce due to nausea and hematologic toxicity. Like any other target agent, it can cause pneumonitis, but the risk is low, less than 1%. And there is concern for myelodysplasia, which is really an issue for those patients who would eventually take maintenance PARP inhibitors for a number of years. There are multiple trials with new PARP inhibitors and also with combinations of various agents. I've included here 2 studies presented at our national meeting in 2015 because they are good examples of current trends in the PARP trials. So the first study I included is a phase 1/2 study with Olaparib and carboplatin. And this study was not restricted to women with BRCA mutations, was actually open to all patients, regardless of their BRCA status and regardless of their platinum sensitivity. And the reason behind that is that PARP inhibitors may work even in women who have an acquired BRCA mutation, not necessarily a germline, an inborn mutation. And through the synergism with the platinum agent, these agents may reverse the platinum refractory status. So this clinical trial enrolled about 40 patients, and majority of them had BRCA wild type, so non-mutated status, and more than 50% of them had platinum refractory disease. And I forgot to say that this was a group of patients heavily pretreated with an average of 7 prior therapies. So it was really a very refractory group of patients. Not unexpectedly, the response rate was higher in patients with platinum-sensitive disease, about 36%. And it was low in platinum refractory patients, 6%. But if we are looking at the progression-free survival, it was very similar, about 4 months. A second study was presented with a new PARP inhibitor, Rucaparib, and the new agents appeared to be more potent. This group of patients was very different. They all had BRCA germline mutations, and they were platinum sensitive, and they had only 2 to 4 prior lines of therapy. So a much more sensitive group of patients. But the response rate was 65% for the whole population, a very good response rate. With Olaparib, let's not forget the previous slide I showed, the response rate is about 35%. but that was after 3 lines of chemotherapy. So Recuparib is quite potent. And in those patients who had a platinum-free interval of more than a year, the response rate was as high as 88%. At City of Hope, we have a phase 2 clinical trial with the new PARP inhibitor, which is called the Niraparib. This study, again, is not limited to patients with BRCA mutations, but requires a certain histology, which is the high-grade papillary serous carcinoma, because patients with ovarian cancer who have this histology have a higher chance of having an acquired BRCA mutation. And the requirement is also for these patients to have failed 3 prior lines of chemotherapy, so it's mimicking, if we want, the FDA approval of olaparib. So the study is open and accruing very well. There are multiple clinical trials which are going on in PARP inhibitors with multiple agents and various combinations. I've included this slide, but if we are looking at the main trends, I would say that the PARP inhibitors are combined with various agents, including DNA-damaging agents, such as chemotherapy and radiation. And the reason behind that is to enhance the DNA-damaging agents, because at the end of the day, the PARP inhibitors are, in fact, repair inhibitors of the DNA damage caused by another agent. A second trend is to combine the PARP inhibitors with cell cycle checkpoints, and again, good preclinical data. In your booklet, you have additional slides, which I removed here in the interest of time, but these slides discuss the preclinical rationale for this combination. There is also a good reason to combine PARP inhibitors with PI3K inhibitors, because these agents increase the activity of PARP inhibition. I wanted to spend some time just discussing the last 2 combinations, one of which is PARP inhibitor and anti-angiogenic therapy, and finally, the combination of these agents with immunotherapy. More than a year ago at our national meeting in 2014, Dr. Liu presented a randomized phase 2 study of olaparib, which is the approved PARP inhibitor in combination with an oral anti-angiogenic agent, cediranib. And this was in patients with platinum-sensitive ovarian cancer with BRCA mutations. And patients were randomized to single-agent olaparib, the approved dose of 400 milligrams BID. At that time, actually, the agent was not yet approved. And the other group of patients received a lower dose of PARP, which was 200 milligrams twice a day, combined with anti-angiogenic therapy. And I included, let me see if I can use that. I included in the slide the result of this study. Basically, the progression-free survival, which was the primary objective of this study, was significantly improved in the group of patients who received anti-angiogenic therapy in combination with olaparib, 17.7 months versus 9 months, so almost doubled. And this randomized phase 2 study led to a phase 3 study, which is ongoing. There's also a good rationale to combine PARP inhibitors with immunotherapy, because ovarian cells, which have germline BRCA mutations, have more tumor-related neoantigen, and intuitively, this will increase the immune response to the tumor. And again, this year at ASCO 2015, a very interesting study was presented which evaluated the tumor infiltration of T lymphocytes in patients with ovarian cancer with BRCA germline mutations. It has been known for years that the presence of tumor-infiltrating lymphocytes is associated with a favorable survival in ovarian cancer. The first paper was published more than 10 years ago. But the current study demonstrated this rationale, this time in patients with BRCA mutations. And they had increased the ratio of CD8, CD4 lymphocytes. And the immune response to the tumor may be another mechanism explaining why women with BRCA mutated ovarian cancer have a better prognosis compared to those with BRCA wild type. One mechanism is increased platinum sensitivity, but there may be an increased immune response as well. So which are the future directions for PARP inhibitors and other DNA repair inhibitors? Is obviously to identify biomarkers. This applies to many new agents. To realize, to understand the timing and the sequence of these agents, and also to balance the risk and benefit. So I think that where are we now? I think we are still in the process of combining these DNA repair inhibitors, mostly with damaging agents, such as various chemotherapies, which I listed. But where can we go? I think the next step is to combine them, as I mentioned, with immunotherapy, with anti-angiogenic therapy, and to also with inhibitors of the microenvironment. And with this, we'll go to immunotherapy in ovarian cancer. There are multiple strategies to enhance the immune response to a tumor. And the first attempts used cytokines and cancer vaccines. The next step was to introduce checkpoint inhibitors in the treatment of a number of malignancies, including ovarian cancer. And finally, T-adaptive therapy, which we will discuss at the end of this presentation. The cancer vaccine, not sure that it is pointing. So the cancer vaccine, give me just a second. I don't know where is the mouse. Oh, I see. Okay, so the cancer vaccines introduce a tumor antigen, which can be a peptide or a full protein, and many times adjuvant are used as well to enhance the immune response. So the antigen is introduced. It's recognized by the antigen-presenting cell, which then interacts with the helper T cell and also with the effector T cell, the CD8 positive, which is activated and is then the cytotoxic T cell against the tumor. There are multiple vaccine platforms, but again, I grouped them based on their main mechanism. And the peptide vaccines, as mentioned previously, introduce a tumor antigen. And in ovarian cancer, the most commonly explored antigen were CEA, NY, so HER2/neu, and I didn't mention in this slide P53. And all the studies showed that the vaccines induced an immune response, but the immune response did not translate in really significant clinical benefit. Dendritic cell therapy was evaluated in ovarian cancer, again, similar to other malignancies. This is a laborious and expensive process through which the dendritic cells are really uploaded with antigen to enhance the immune response and to finally activate the T cells. Similar to the vaccines, this strategy induced an immune response, but they did not have so far significant clinical benefit in ovarian cancer. Finally, viral vaccines have been evaluated, and the most commonly used viruses are vaccinia and pox viruses used as vectors to express various tumor antigens. At City of Hope, Dr. Diamond and his team, they have developed a P53 vaccine, which is recognized by the antigen-presenting cells in the skin. These cells travel to the lymph nodes, and they prime a T-cell response against the overexpressed P53 protein in tumor cells. And especially in ovarian cancer patients with high-grade papillary serous histology, P53 is expressed in more than 90% of the cases. In this clinical trial, we are combining the vaccine with gemcitabine. This is a chemotherapy agent which has anti-tumor effect on its own. And it may potentiate the immune response because it affects the regulatory, the myeloid suppressor cells. I included the schema of our study, so women receive a total of 3 vaccines at the end of each cycle of gemcitabine, and subsequently they continue gemcitabine until progression. The study is active and accruing well. In summary, vaccines have been explored in ovarian cancer, but I think there are still a number of issues. They induce an immune response against the vaccine many times, but not necessarily against the tumor. They also recognize neoantigens, but many times they are just the reflection of passenger mutations rather than pathogenic mutations. And the immune response induced by the vaccines is not long-lasting, and the response is suppressed by the tumor microenvironment. So in conclusion, I think that the vaccines are back. I think this was one of the messages at ASCO in 2015, but not as single agents, perhaps combined with chemotherapy, with checkpoint inhibitors, or with other immune strategies. Checkpoint inhibitors have been evaluated in many tumors, and I think so far they have proven significant benefit in melanoma and in non-small cell lung cancer. We already have 2 FDA-approved agents in this setting. So the checkpoint inhibitors suppress the immune response. The PD-1 receptor is located on the T cell, and its ligand, the PD-L1 or PD-L2 protein, they are expressed by the tumor cells and many times by the microenvironment. Through the interaction of PD-1 and PD-L1 agent, the immune response to the tumor is suppressed. So a number of agents trying to block either the receptor or the ligand have been developed. In ovarian cancer, we have preclinical data that PD-L1 expression is associated with a poor prognosis. So it is a prognostic factor, and appears to be also a predictive factor for response. The slide I included is not from an ovarian study, but rather from a melanoma study presented this year. And the idea was that the higher the expression of PD-L1 in the tumor, the higher the response to PD-1 or PD-L1 agents. This remains a subject of debate because we know that there are patients without PD-L1 expression who still respond to these agents. And at the same time, not all patients who have PD-L1 expression have a guaranteed response. But as a general rule, some correlation exists. A number for the first time, I was glad to see at ASCO this year that PD-1 and PD-L1 agents have finally been reported in ovarian cancer as well. One study used avelumab, which is a new PD-L1 agent with a long half-life. The study was evaluated in the context of a multi-histology phase 1/1b protocol. But this was a study which at the end enrolled a total of 76 patients. It's the largest cohort of ovarian patients. And it was used as single agent at 10 milligrams per kilogram every 2 weeks until progression. And being a phase 1 study, had safety and tolerability as a primary objective. I included here the response. I would caution you that the response was presented only in the first 23 patients. 50 additional patients were enrolled, but they were not reported yet. The response rate was only about 11% by RECIST criteria. When the immune criteria were added, the response was in the range of 15%. Again, it's probably too early for the final analysis. And if we compare with melanoma and non-small cell lung cancer, we'll see that in ovarian, the response rates we've seen so far are a bit lower. This study did not select patients based on PD-L1 expression. And I did not include, but most of them were heavily pretreated, having failed more than 4 prior lines of therapy. Another agent that was evaluated in ovarian cancer is pembrolizumab, which is a PD-1 inhibitor. Again, this is approved in melanoma, and recently it has been approved in non-small cell lung cancer. And in this study, about 26 patients with ovarian were treated, all of them, again, heavily pretreated. Pembrolizumab was given at 10 milligrams per kilogram. I'll tell you this is a high dose. For instance, the dose of pembro in non-small cell lung cancer is 3 milligrams per kilogram. So in ovarian, they used a higher dose. And patients were selected based on PD-L1 expression, but it was a very low bar, just 1% expression in the tumor. And as we'll see, the response rate was again in the range of about 11%, the overall response rate. But those 3 patients who responded continued to do so. One of these patients was more than 11 months on trial and responding, and the final analysis is still pending. These were all very early reports at ASCO. And finally, nivolumab was presented both last year and this year. The patient population was less heavily pretreated. Nivolumab was given at a dose of either 1 or 3 milligrams in platinum-resistant ovarian cancer. In terms of correlative studies, we haven't seen the final analysis, but the response rate was higher, was 23%. And there was an update this year in 2015 showing that, again, those people who respond do so for a long time. So they had responses between 6 and one patient, I think, was 20 months. So what's the final about PD-1, PD-L1 blockade in ovarian cancer? I think it's premature to have final statements. I think that both antibodies have a very similar toxicity. There was a statement at ASCO that maybe PD-1 agents may be a bit more effective in ovarian cancer. In my opinion, it's too early to state that. We are still evaluating the responses and the duration of response. And the same subject of debate, similar to other malignancies, should we look at PD-L1 expression and what should be the bar, what should be the limit? We'll move now to T-cell to adaptive therapy in ovarian cancer. So T-cell therapy is another immune approach by which the T-cells are removed from the patient, expanded in vivo, and they infused back with the intent to provide active T-cells against the tumor. There are different mechanisms this can be done, and I listed 3 of them. The tumor-infiltrating lymphocytes, the cancer-specific T-cell receptors, and finally the CARs, which are genetically engineered T-cells expressing special receptors on their surface. Tumor-infiltrating lymphocyte was the first approach, and this was used in melanoma and also in ovarian cancer in the late 80s, early 90s. And this approach requires mini-surgery, so some debulking of the tumor, in order to isolate the tumor lymphocytes. The tumor lymphocytes are then expanded, and they are infused subsequently back to the same patient. In order for these lymphocytes to survive and to be active, it is common in all these T-cell approaches to use lymphodepletion. So prior to receiving the active T-cell, the expanded T-cells, patients receive chemotherapy, which causes lymphodepletion. And the purpose is to remove those regulatory T-cells, which are the regulatory cells, Tregs and MDSCs, which are suppressing the immune response. So this approach has been active and effective in ovarian cancer, but it has not been adopted because it is a very laborious process. It is very intense, very costly process, and difficult really to perform in practice, plus it requires surgical removal of the tumor. So the next approach was to generate tumors that express the T-cell receptor. These are cells which are genetically modified. So in this scenario, the T-cells are isolated from the patients. They are then, viral vectors are used to encode genes that can express the tumor receptor on these genetically modified T-cells. And the receptors are usually much stronger than the natural ones because the idea is to allow a strong interaction between the T-cell and the tumor, the cancer cell. So these are genetically modified lymphocytes which express a new TCR, more potent than the natural one. And then these T-cells are infused again to the recipient. As mentioned previously, patients are receiving lymphodepletion prior to the T-cell infusion. The major disadvantage of this approach is that the antigen recognition, so in other words, for these lymphocytes to be able to recognize the tumor antigen and attack the cancer cells, this interaction requires is HLA restricted. And this has been, I think, the major limitation of this approach. At City of Hope, we do have a phase 1/2 study with genetically modified lymphocytes, which are expressing an enhanced TCR specific for the NY-ESO receptor, the NY-ESO antigen. And this is conducted in patients with heavily pretreated ovarian cancer. Why the antigen NY-ESO is because this is a testis antigen that has very restricted expression on normal tissue, so it's pretty much limited to cancer cells. It is seen in about 35 to 40% of ovarian patients. But as mentioned previously, in order for these T cells to recognize the antigen, the process requires HLA recognition as well. And I think this is the major limitation of this study. After screening for HLA typing and the antigen expression, only 10% of patients are eligible for this study. And as I said, at most of our meetings, we screened at City of Hope 90 patients and identified 4 or 5. So it is very intense. But the study is active and accruing at City of Hope. It was initially activated only at Roswell Park at City of Hope, and recently MD Anderson joined us. The last approach is, that I will present is with CAR cells. These are T cells genetically engineered to produce special receptors on the surface called chimeric antigen. This process does not require HLA interaction, so I think this will be the major advantage of the approach. The CAR T cells have an exogenous protein, which is really an antibody, and then they have an endo protein, which is very similar to the transmembrane part of the T cell receptor. There are several generations of CAR cells, and all of them vary between the intracellular signaling domain. So with the second generation, there are 2 molecules which engage more pathways, and with the third generation, there are actually 3 signaling domain in the intracellular portion of the CAR. We don't have a lot of information in ovarian cancer. This approach has been studied extensively in hematologic malignancies, but in ovarian cancer, there are ongoing trials looking at folate receptors and other tumor-specific antigen for the generation of CAR T cells. So with that, I concluded about immunotherapy in ovarian cancer, and will change the subject now to discuss HIPEC, which is the hyperthermic intraoperative intraperitoneal chemotherapy. This is a new approach, or I would say an expanded approach now in ovarian cancer. It has been studied in those malignancies associated with carcinomatosis, and the initial studies were conducted in colon cancer, as we'll see. So the principle of this approach is to perform extensive surgery, peritonectomy with removal of the visible disease, and then during surgery, the peritoneal cavity is washed with heated chemotherapy in an attempt to destroy any residual microscopic cells. Peritoneal carcinomatosis is seen primarily in gastrointestinal and gynecologic malignancies, and this complication is associated with a very poor survival, as listed below. When studies were done in the late 90s and early 2000s in colon cancer, and at that time I will say that some studies still used 5-FU-leucovorin alone, but then subsequently irinotecan was added, the response rate and survival was very different in people who had peritoneal carcinomatosis versus those who had, for instance, liver metastasis. Is included here. So it's a dismal prognosis for peritoneal carcinomatosis. So how can we improve on this serious complication? And as I mentioned, one approach is to proceed with a combined modality with extensive peritonectomy followed by chemotherapy, and there are different ways that chemotherapy can be done in conjunction with surgery. One approach is the HIPEC, the hyperthermic intraoperative chemotherapy. Another approach is to deliver early post-op IP chemotherapy, and finally, delayed post-op IP chemotherapy. I will only discuss the HIPEC, so the first one. This is nothing new. Choosing the right patient would probably give better results. And the right patient for HIPEC means a patient who has primarily intra-abdominal disease. Those patients who have extensive adenopathy or hematogenous metastases are not the best candidate for this approach. And the goal of surgery is to resect all visible disease or to reduce this to a minimum. There are various prognostic factors have been developed, and I listed the most commonly used one, which is the Peritoneal Carcinomatosis Index used by surgeons as a predictor for the ability to perform a good reductive surgery. So the score is calculated based on the distribution of the peritoneal nodules in various regions in the abdomen and pelvis, so is the distribution, and also the size of these nodules, which will give a final score. And this will be a guidance for the surgeons in terms of ability to perform surgery and the overall prognosis after this complicated procedure. So as mentioned here, if the score is less than 10, these patients have a very good survival compared to patients who have high scores, meaning extensive bulky disease. Survival, again mentioned, is reflected here by the survival curve, very different in patients with low scores versus high scores. In colorectal cancer, phase 2, and as I will mention, a phase 3 study demonstrated that this aggressive approach was associated with improved survival compared to historical data. This study conducted in colorectal cancer led to a median survival of 19.2 months. Again, traditionally with intravenous chemotherapy, it was less than 6 months. And obviously, in those patients who were able to undergo R0 resection, the survival was even much better. A phase 3 study, again, colon cancer, not ovarian yet. This study randomized patients between standard therapy, meaning surgery or not, followed by chemotherapy, with the experimental arm, which utilized HIPEC and standard adjuvant therapy. I will caution you that this study was conducted in the late 90s and early 2000s. And at that time, the chemotherapy that was used was 5-FU-leucovorin. We know that since then, FOLFIRIN, FOLFIRINOX really improved significantly the ability of chemotherapy. So this study, I think it's already outdated. But at that time, it demonstrated a significant improvement in survival for those patients going through HIPEC. These are some slides from Dr. Morgan, you can tell. So what are the complications from this approach? There could be significant complications because of prolonged ileus and fistula, infections, obstructions. So about 25% in the initial studies. I think the results have improved in time, but originally 25% of these patients did have significant complications and even high mortality. I think that the more recent studies, especially those conducted in GYN malignancies, have much lower complication and mortality rates. So I included here a HIPEC study, this time done in ovarian. It was presented again, ASCO of 2015. It was a retrospective analysis. This is not yet a common approach in ovarian cancer. It was an analysis done by evaluating the network of 5 cancer centers, and these patients were treated between 2009 and 2013. About 53 patients were identified, and 40 of them had platinum refractory disease. The median survival was 26 months, obviously much better for those people who were able to undergo an R0 resection compared to those patients who had residual disease. And the same was true for progression-free survival. I think one of the important messages was that for the whole group, the progression-free survival was 10 months, compared to about 4 months for the previous therapy. We know that in ovarian cancer, the remissions tend to be shorter and shorter. So to have a previous remission of 4 months, which now led to a remission of 10 months, it is significant in this malignancy, especially that these patients were heavily pretreated. So the conclusion of this retrospective analysis was that HIPEC is feasible in ovarian patients, and obviously needs to be studied in a prospective manner. I'm close to end, but I don't know if I can go to the next slide. I wanted to show you that at City of Hope, we do have a clinical trial. It's a HIPEC study, which is accruing well and is enrolling both patients with platinum refractory as well as platinum-sensitive patients. And Dr. Dallinger, who will present next, is the PI of this study. There we go. So this is the clinical trial that we have. So the conclusion about cytoreductive surgery and HIPEC is that this is a promising approach, but it is not for everybody, and we should start by excluding those patients who have extensive disease and do not appear to be candidates for a complete resection. Many times patients are referred way too late in the course of the disease after failing all standard chemotherapies. We should not enroll patients with poor performance status, and perhaps not those with aggressive histologies. Carcinosarcoma would be an example of that. So then who should be considered for this? Those patients who have limited disease. Again, the goal is to perform complete cytoreduction. Those who still have some systemic options and they maintain a good performance status. And with that, I will conclude, and I'd like to thank you for your attention. Thank you.
Thanks very much, Mickey. We have time for some questions if anyone has any. I have a question for you, though. Okay. How would you, if you had in your dream of dreams, how would you go about combining treatments with the new PD-1 inhibitors in ovarian cancer? And why do you think there's a difference, for example, you know a lot about lung cancer too, between the lung cancer responses and potentially ovarian cancer?
Okay. So I think in terms of immunotherapy, I think a good approach would be to combine that with other immune strategies. I think vaccines and checkpoint inhibitors would be a good approach because the vaccines will deliver extra antigen, which will actively stimulate the immune system. And given checkpoint inhibitors will only expand, will unleash the brake, so will make this final T-cell response stronger. So I think vaccines and checkpoint inhibitors would be a good option, and it's not a very high-risk proposition. So I think that's an approach. I think that chemotherapy with those chemotherapy agents that have immunomodulatory effect, like Cytoxan, perhaps even dose-dense Cytoxan or high-dose Cytoxan and checkpoint inhibitors, that would be, again, a strategy to enhance the response. And for other chemotherapy agents, I don't think we know a lot. The question is maybe some of the chemotherapy agents may suppress the immune response. I would be very careful in which combinations, but there will be another approach. I haven't seen much yet, and I was thinking of the rationale, which I cannot find, whether anti-angiogenic therapy makes sense. Unknown, although, as I said, with PARP inhibitors, it did help a lot. So maybe we'll see some of that in ovarian. So that's about the combinations. Now, the difference between ovarian and lung cancer, I don't think it's known, but what we've seen, even in the T-cell study compared, where we looked at the immune response in the ovarian patients compared to other histologies like sarcoma, it is clear that ovarian patients are more immunosuppressed. Does it have to do with their multiple lines of therapy, with the early introduction of platinum agents and multiple platinum therapies, which maybe caused irreversible bone marrow suppression and affected somehow even the number and function of T cells? I don't think that's known, but preclinical tests did show that.
So maybe we need to come in earlier with the checkpoint inhibitors.
Right.
We'll see. It's all research. Thank you very much.
Thank you.